Hi, everyone, and welcome to the American Heart Association Center for Health Technology and Innovation webinar on AI and everything and that we're thinking about in regards to deploying AI responsibly. And I'm really excited about today's panelists because you're going to hear from leaders across healthcare systems in the United States grappling with questions around what are the promises and pitfalls of AI tools that are being developed, deployed, and evaluated today. My name is Sneha Jain. I'm a assistant professor in cardiology at Stanford University, and I serve as the director of our Guide AI lab there, working with the hospital system to deploy AI tools and evaluate them. So to kick us off, I would love if everybody on the screen could introduce themselves, and I'll just go by who's on my screen first. We'll do quick introductions and then we'll go into a couple questions. AJ.
Greetings, everybody. My name is AJ Blood. I am a cardiologist and clinical trialist at Brigham and Women's Hospital in Boston, Massachusetts. I'm also the co-founder and CEO of AI with Care, a company using AI to accelerate clinical trials. So nice to be here.
Thank you, AJ. Dave.
Thanks, Sneha. So I'm Dave Newman. I'm an endocrinologist, so the lone non-cardiologist on the call. I'm sitting in Fargo, North Dakota, in the beautiful Midwest. I am the CMO of virtual care and digital health at Stanford Health. No T, Stanford.
Wonderful. Asif.
Hi, my name is Asif Ali. I'm a clinical assistant professor at UT Medical School here in the Texas Medical Center in Houston. I'm also the director of CINA Research Institute. We have a AI health tech organization that uses research to beta test all of the AI that we're using.
Wonderful. And last but certainly not least, Michelle.
Hi, everyone. I'm Michelle Albert. I am a professor of medicine at the University of California in San Francisco, where I also serve as the Dean of Admissions for the medical school and the director of the Center for the Study of Adversity in Cardiovascular Disease and a past president of the American Heart Association. Thrilled to be here.
Wonderful. So to kick off our conversation today, I would love for each of you to share one promise of AI and one thing that keeps you up at night. And we'll have each person share, but then I'd love to just have a discussion amongst all of us around a few themes that might emerge. And let's go in reverse order this time. So Michelle, if you don't mind going first.
Hi, everyone. So I am going to try to bring a medical education lens onto my comments. I think that is a space that where AI is extremely promising. However, there is a disconnect between, sort of the innovations happening in AI and from a technological level, and actually preparing our workforce to be able to adequately utilize AI. I think promises include working on building clinical skills, evaluations for medical students and residents and faculty, among many other things. You asked for one promise, but there are many promises. But risks are there. And these risks include sort of the activation of critical analysis skills, the risk of, plagiarism, academic integrity issues, and the ethics of AI is something that institutions and regulatory agencies need to lean into as we begin to prepare our workforce. Our workforce is already using AI, but we have to do it in a coordinated way.
Thank you so much. And I think I would love to get into this concept of educating in this new AI era across the continuum of our workforce, both our trainees all the way to some of our most senior physicians. So we'll save that for a little bit later. Asif, if you don't mind going next.
Sure. So I think one of the biggest promises in AI is really making our lives easier, taking the mundane. So taking processes where we as physicians, we train to do higher cortical thinking, but to be able to do that thinking, we need data input. And that takes a lot of time. Doing the history taking, collecting information from the ER, from the hospitals, from other individuals. So that data collection, that mining of that data, whether it's structured or unstructured, is takes a lot of our time. And what we really want to use, I think, AI tools is using those mundane, often processes that take us a lot of time to make those a lot more efficient. So I think looking at some of the mundane processes is where I think one of the promises of AI early can help us early on. What keeps me up at night is really the inherent biases that already exist in the healthcare system. AI is not creating biases, it's just replicating what we have out there already. And I think there's, processes like reinforcement learning from human feedback that can help us through those processes. But I think just calling out that biases exist and how do we tackle those, how we do that governance and that policy and make sure that we call that out is really important to me. And that keeps me up at night.
Thank you so much. Such an important point. Dave, let's go on to you.
All right, so my promise is that AI is going to increase access and improve earlier detection for lots of chronic disease models. We've already seen it here. In rural America, we've got lots of problems with zip code-based disparities. We don't have enough docs, we don't have enough nurses, and technology is the only way that we can enable care. The pitfalls is when we have awesome technologies, awesome AI models, but we can't operationalize them. The people on the call are doctors, right? So we're really good at treating patients. We're not super good at operationalizing things. And my fear is that as we head towards the future, we're not going to have the staff to make a lot of these promises come to nature. Example of this is we have got homegrown chronic kidney disease models, colon cancer models that are validated in our patient populations. We haven't been able to be as successful as we wanted to be until we involved all of the people on the front lines. We have to be very intentional about this. And I'm super scared that all of the really great things that are going to help patients aren't going to come to fruition because of that.
So important. It sounds like it's about both engaging the front line, but also ensuring we have capacity to act on, let's say, if an AI tool identifies someone at risk for a specific chronic disease, being able to actually take them through the healthcare pathway to get them the care they need. It's one thing to diagnose, it's another thing to treat. Um, that's great. AJ.
Yeah, again, it's hard to follow so many great comments from these other amazing speakers. But yeah, I think to follow on the last comments by Dave, I think the change management is going to be really key, and actually preparing the people who have trained. We've got a lot of good data. It's hard to change behavior, and it's hard to change the way people have, trained in their medical training or done things for years or decades, and incorporating these new tools. And that's really what I see this as. This is just a new tool. It's a very powerful tool. It's a transformative tool in so many ways. But making sure that we're doing it in an intentional way, in a safe way, in a responsible way, in a way that is evidence-based and validated, and really recapitulating any new tool or technology rollout as we do that is going to be really essential. So I think having the right oversight, the right guidance, the right safety, the right checks. Again, we talk a lot about human in the loop as kind of the first iteration of that, but I think that's going to involve, and we're seeing, I think the state of Utah, allowed for the first time prescription refills, all right, to be done by AI. I think there's a lot of hype around that. What does that mean, and how is that going to change patient experience, practice, access? Again, they're doing it in a relatively small niche area to give experience and build the use cases around how this can be done safely and appropriately. I think we have to do that in a much more rigorous way in each and every rollout of these new tools and technologies. And I think that's going to be a really important way to make sure that it's clinically appropriate, safe, responsible, and scalable in a way that touches hospitals and health systems from the large academics to the small rurals in a way that similarly uplifts both providers and patients.
That's so great. AJ, you packed so much in there in your comment, which I think we should tease apart. No, in a great way, in a great way. There's the change management aspect, but then there's also a little bit around how do we think about the right oversight of AI tools across the continuum of risk, let's say. Higher risk tools probably need higher oversight, lower risk tools, maybe less oversight. So we don't stretch thin on some of our kind of regulatory efforts. But the question I would love to hear from all of you, and feel free to just, hop in or raise your hand, let me know that you're want to jump in, is what is it that the doctors at the front line, what should we as AHA or leaders within healthcare systems be thinking about what they need to equip them for this new era of AI augmented care? What information should they be given? And then if you feel like going into this, a little bit about like what support can we give them given that they are the last line of defense of making sure patients get the right care. And there are concerns, especially when we use generative AI tools. Let's say they're typing in, checking something from the chart, typing in and chatting with the chart, which is a feature we have at Stanford. At the end of the day, whether the information is correct or not and how you act on it still relies on the doctor. And that quality check is still on the doctor. And that's hard for humans. If something is 99% accurate or 95% accurate, identifying when it is wrong is something that's difficult. So, how do we support our frontline clinicians? Michelle, please.
I have some comments in response to what you just said. I think first and foremost, I think all of us I who practice in medicine went into medicine because we wanted to have that human interaction with patients, and to have that human centeredness. So I think that one of the things that we need to actually really focus on in the front line is how we preserve and utilize AI in a ethical manner to preserve the human centeredness of healthcare. And I think that that is something that patients are concerned about. It's something that doctors are concerned about. So as we think about the front line, I mean, I think that, we can diagnose and we can, sort of give people, sort of, a prescription or a diagnosis. But at the end of the day, I think that that's a place of focusing in on how we improve interactions with patients and improve the quality and the accuracy of information that people get, is something that I think all parties are concerned about, and we need to actually really focus in on those issues. And then related to comments that were made earlier regarding early diagnosis, early diagnosis is worth nothing if at the end of the day the finances aren't in place for people to get the care that they need, and also that, sort of stressing patients out, right? And so we need to actually pay attention to all of those issues, as we, sort of move forward with this. And I feel like when people have a resistance to AI, those are some of the concerns they have as they confront this, sort of new territory.
Yes, Asif.
Yeah,
I
I
think
think
that's
that
a
what
great
you said
point.
was what they want. Sorry, Steve. Yeah. When I ask doctors what they want, is they kind of want their life to be better and they want to improve their patient's life. Ambient is really hot right now. If you haven't experienced ambient, it is amazing. So I'm using it in my clinic now. For the first time, a patient stopped me and she's like, "Wow, you're looking at me in the face. That you're actually making a connection instead of looking at the computer screen." The statistics are amazing. I get my phone goes off. I can't even shut my phone off when ambient goes down because so many people are upset. That we've had doctors that have been on naughty lists because of documentations that now they're going to their kids' recitals, like they're getting life back. And I firmly believe happy doctors are good doctors. But I agree with Michelle is that we've got to find a way to pay for all this. There's unbelievable potential, but we've got to find a way to make it cost neutral for not only providers but patients as well.
Asif, I saw your hand up earlier. Yeah. Mhm.
Right, thanks. So as physicians, patients come first. So I think we always have to think about where patients in this, right? So if you look at JAMA Open, I think this was last year that was published, it said patients trust in healthcare systems to use artificial intelligence. The summary of that article said we trust in our physicians and the healthcare systems to determine are they the right tools to be used on us. Like they're willing to use AI tools, but they want to have that trust in the delivery system that we're looking out for their best interests. And I think the second part is really understanding digital health literacy. Not everyone has um, we have a spectrum of different ages, different ethnicities, different genders who may interact with artificial intelligence differently, but I always start with patient first. So what do the patients feel about their digital health literacy? And then, where's the transparency of those tools? Was I included in the cohorts? Was the LLMs applicable to me? I mean, it was LLM on a 65-year-old white male, or was it trained on a 30-year-old African American female? So I think the trust but verify, that's a term that we always use. We need to start with the patient first with their digital health literacy. I think we also have to look at the digital health literacy of the physician. I know Pat Dunn from the American Heart Association's made some great inroads in that, and the HA, that's one of their kind of big initiatives is to make sure that all the stakeholders have that digital health literacy and know what they're buying into.
Yeah, if I
AJ.
could,
Mm.
great comments, also. I'll just say, I think just to jump in on that, right? Like, I think there's another report that just came out, 40 million people a day are asking ChatGPT health questions. Right. So like whether or not clinicians or physicians are taking this up and using it, our patients certainly are. And I think it's really important for us to acknowledge that, understand that. And I think, just to jump on some of Dave's earlier, notes there as well, right? Like, I think really the tools that we've seen proliferate massively within health systems using AI, really real AI tools, are Ambience and RPM. RCM, revenue cycle management. And we don't see that as much as clinicians, but on the back end, I assure you, your administrators are, if not using it, thinking hard about it. And I think, that's interesting, right? Because the value propositions of that, well, again, it's great. And I think some of those stories are shifting to talk more about patient-centeredness and focus and attention and kind of returning to the patient as the core of who we are and what we like to do as a profession. I think, the reason they're getting funded, truthfully, is because there was an ROI story to be told, right? You're going to be able to see more patients with Ambient. You don't have to document as much. We're reducing pajama time. You're going to be more efficient. You're going to be happier and more productive. That's why we can invest in this, right? For revenue cycle management, right? We're going to make more money from the work that we're already doing because we're going to be more efficient with our billing and administrative processes such that we can actually tell a value story there. So I think that's one challenge that we're currently facing with a lot of these other tools, which again, maybe we're diagnosing things earlier, maybe we're providing better care, more holistic care, more patient-centered and personalized care. Those things are all extremely important. I think some of the challenges with actually implementing and scaling those has been, how do you actually tell the value story around that? And how do you make an economic story such that the health system or whoever the insurer or the payer is in that situation is going to be motivated to invest? And I think, one thing we talked a little bit about was, we don't want to pass by, financial toxicity onto the patients. This shouldn't be an added cost. We really, believe this is a technology that is extremely valuable. But the health system as status quo is already unaffordable for so many across the country and across the world. So how do we do this in a way that isn't just adding to that and is not one more line item bill that a patient has to worry about every time they decide not to seek healthcare?
I think also with any invention in medicine, in any invention period, at the end of the day, following up on your comments, AJ, is that you're talking about outcomes, right? So the economic outcomes as well as the patient outcomes. And, for me, when I think about problems, I want to move back and start with some principles, right? And when I think about, sort of principles related to AI, whether it's like in the healthcare delivery setting or in the education setting and so forth, I like to think about a few items. First, that we need to continue to have a human-centered focus. We have to make sure that things are ethical and that when AI is used, that we're transparent about the use of AI and communicate that to our stakeholders, whomever they are. There has to be monitoring and regulation of the processes that get used. We have to provide equitable access to AI. So like everybody has to be able to have equitable access. So access and access means training as well as access to the technology. There has to be, continued, sort of development, whether that's professional development on the workforce side, algorithm retraining, etc. We also have to protect people's data and privacy. These are all, sort of, I feel like big picture issues regarding governance and anonymization, etc. So I do think as we, so are continuing this conversation, that keeping those large principles in mind is really, really important because it's not, I don't want to be the downer here, but it's great to be excited about this. And there's a lot of, sort of potential benefits. However, we don't just want this to be something that, is great for a few people.
Mm.
And at the end of the day, there's no improvement in disparities in conditions. There's no improvement in as AJ was mentioning, the decrease in dollars or financial toxicity or any of that. Yeah.
If I can just jump really quickly right back in, I'm so sorry, I don't want to dominate here, but Michelle, amazing comments. First of all, really appreciate that perspective and those insights. I think one thing that I am feeling acutely as somebody working in the space and have a startup company in the space, the other side of that, regulation, monitoring, guardrails, I think they're important, and it's important to monitor, manage, and make sure that we're doing this safely, appropriately. I think the other side of that coin is it can take 9 to 12 or more months. Dave, you've probably lived this to get a new technology, innovation, solution, partnership up with any new company with a large health system, and even small and medium-sized practices. There is a lot of friction and red tape there. So I think, healthcare for good reason, right? Like we want to do things appropriately, safely, evidence-based, making sure we're putting patients first. I think those are all key. I think that the other, the counterbalance there is patients are using this. Patients are taking this up. They're dropping their chest X-rays. They're dropping their doctor's notes in there, and they're asking questions about it. So I think if we are too ossified in the way that we respond to that, or build tools, technologies, platforms, like things that can actually help us and equip us to better care for patients, I think that's going to actually be worse off for us as a profession. There's already a big trust gap. We've unfortunately had some major challenges in the past couple of years. Whether it's the COVID pandemic or politics or whatever it is that's caused some of these rifts that we've seen with the healthcare profession. I think the further we fall behind from some of these technologies, which we're not very good at rapidly uptaking and implementing, I think that's actually there's a risk in moving too slow here.
Let's double down on this point, because I think that this, and it ties into some of the questions that have been asked around, AI is here to stay for now. The risks are there. How do we appropriately mitigate those risks while still moving quick enough? And I think that just to frame this a little bit, we are now using generative AI in our everyday life. I think a lot of people use things like ChatGPT or Claude or something many times every day. And it's would be strange if you're not using that in your day-to-day practice. And we've seen some things really take off. It's now penetrated over 50% of the physicians across the United States have logged in and used open evidence, which was the fastest uptake of most things in healthcare and has totally disrupted how a lot of people used to look up data, versus what AJ is talking about, where things within healthcare systems can get updated really slowly. So, how do you think in your individual institutions about responsible AI use? What processes are there that might help mitigate against risk, and think through the ethical questions that might emerge? And how do you make sure that they stay really agile? And I'm happy to share Stanford's opinion too, but I want to get some other thoughts first.
I
I
think it
gave you guys the
depends
easy
a little
question.
bit on the user case because
Mhm.
there's complexities in everything we do. I mean, if you look at AI with imaging, we've been using that in chest X-rays and now CTAs and echocardiogram as well. Um, the fact of the matter is the patients, like AJ was saying, are already using. We used to call it Dr. Google, and now it's Dr. AI. So the patient's already coming in with their own preconceived notions. Problem is, as we all know, it's always asking the right question of AI, and that's subject matter experts and the prompt engineerings that we use. Um, to use the AI responsibly, again, it really depends on the user case. I break down the patient continuum in pre-engagement, engagement, post-engagement. So I already use tools now that collect information from the patient before they even see me, and it writes about 60% of my note. I have to trust but verify when I see the patient. The engagement, we all know that as ambient listening. AJ talked about that earlier. And then post engagement is really like our remote patient monitoring, and how do you do behavioral change for adherence after. We're publishing papers in actually all three areas. I can go back to a publication we did 2 years ago at the AHA, where we actually looked at three LLM models and we fed those LLM models. It was ChatGPT, 4, Grok, and Gemini. And I think one area that I just want to point out about responsible AI, the models that we have today are the worst models we will ever have because they'll just keep on learning. Um, the hallucination rates were actually quite staggering when we published our data when it came to feeding 10 case studies published in the American Heart Association to see how these LLM models worked. So I think part of the conversation here is when you have to look at the user case, you have to look at the large language models, and you have to see how they were trained and what they were trained on. And you can't just apply it to everything. We talked about this earlier that you have to apply the models based on the cohort of patients that you're looking at. And if they're not part of that cohort, these LLMs will always give you an answer, but then it may not be the right answer. And so the more money we pour in and the more data sets that we train these models on, the better they'll get. So as of today, these models are good. They work, but that may not be good enough when we're taking care of patients' lives. And that's where keeping the human in the loop, a subject matter expert, making sure that we, look at that information and double check it is still going to be very paramount until these LLMs become to a level where, we don't have to do that as often.
Yeah, and I guess LLMs are even just one of the AI tools that we use. If we think across the continuum, there are traditional predictive models that has the same kind of issue around training that I think you're talking about. LLMs often the foundation models are generated on just massive amounts of data from the internet, but might be fine-tuned on specific, subsets. And then agentic AI, which AJ alluded to earlier about what's happening in Utah right now around actually thinking through not only processing but acting as an autonomous agent and what that means. And so to bring the question back a little bit to what do we as healthcare systems, as the AHA, what can we do to think through it? One thing I would love to hear about from the group is how we need to shift, or if we need to shift, the way we think about evidence generation for AI augmented care. We as cardiologists, maybe even as our endocrinologist here, very familiar and comfortable with clinical trials, right? But these tools change over time. Their performance can change over time. The underlying data and the underlying disease prevalence, all of that can change over time. That I think there's a lot more importance on focusing on monitoring over time, or phase 4 kind of work, if you will, and baking that into a responsible AI lifecycle. So at least at Stanford, what we've done is we have what we call RAIL, Responsible AI Lifecycle. There's a firm assessment, an assessment that's done upfront to evaluate the ethical, financial, and clinical usefulness implications of a certain AI tool. It goes up for a vote about whether it goes through. And then there's a plan that happens before something is deployed around how it's going to be monitored. And I think critically, it's tied to actions. If there are certain changes around certain parameters, a model is retrained, or there is a model could even be decommissioned. And it is celebrated if we decommission a model that's no longer serving our patients or our employees. And I think that's been exciting because it's been a shift in how we usually think about adoption of tools, technologies, medicines from what we are used to. So do people have thoughts around that?
Well, I mean, I think what you're getting at, Dr. Jain, is, sort of what are recommendations for institutions as they approach, the utilization of AI, right?
Yes.
And I think in that context, from a big picture perspective, there are a few items. You mentioned becoming ethical stewards of AI is a core soil of it. I think another component of it is institutions all have policies, right? And those policies, will have to, sort of reflect, AI. So policies might need to be revised or new policies created to regarding generative AI and other types of AI. I think that also it's going to be important, and I know this conversation is not at workforce yet, but the workforce is important. That how you support a workforce with regards to the tools for them to use for AI, and also giving them that flexibility. And how do you, sort of maintain innovation and originality and creativity from these are like the big institutional, I think, like questions. I mean, I think the use case is really important. But you can end up having, 3 million or trillions of use cases, right? But there has to be something that governs all of that in terms of the approach.
Yeah, I'm going to
Jain.
take it in a little different direction and touch on something that Michelle said in our prep call yesterday is how do we expand this to everybody? So it's one thing to be at Stanford or the Brigham or UCSF and have access to all these teams, but how do we get this to our critical access hospitals? My buddy Brad, who's the family practice doctor in Valley City, North Dakota, who's seen 30 patients delivering babies, delivering his own vaccines, he doesn't have time to do AI governance, right? So we have to get the information to him in like a 3 to 5 minute sandbox environment so he can get it to his patients. But it has to get to everybody to be equitable. We can't just do it in the academic class.
I think that's really well stated. And the American Heart Association, I think, has shown a lot of commitment to this, which I'm really happy about. There was just a science advisory published in October on pragmatic evaluation and monitoring of health AI tools, saying like, yeah, there is a way that certain institutions with resources are able to do it, but what's some of the bare minimum? What are the basic questions to be asking that I think is really powerful and hopefully helpful. So I encourage people on this call and listening in on this webinar to check it out, to see if it resonates, see what needs to evolve. One thing that is that we're all figuring it out as we go along. And the AHA is also, I know, committed to figuring out how best to support all hospital systems across, the continuum of resources and getting this right, doing responsible AI right. And I think this webinar is one of the many to come on AI and responsible AI use. Let me take a moment here and to answer some audience questions. Let's pose some of these. And I think it'll get to a little bit of the workflow conversation that Michelle was talking about. So this is from Lauren Poole. For trainees and people just starting out in their careers, what are steps they should be taking now to understand both how they should use AI in their future practice, as well as how their patients are using AI? Also, do you see any way that students and trainees could use AI as an educational tool for themselves?
So I can start with the 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 latter part of that question. When you asked the question in the beginning about the promises of AI, so I want to lean in now to the promises of AI in the context of medical education. I mean, there are several. One is test preparation, right? Taking data and generating exam questions that persons can utilize for standardized testing. The downside of that is that oftentimes the AI generated questions and so forth are not open-ended and don't necessarily stimulate the more critical thinking parts of assessment. Another component would be evaluating learners and faculty for applications that they may have to residency. There's something called the medical student performance evaluation, which actually pulls lots of information from various sources to then present it to residency programs. It can be pretty clunky. And AI can be used in that context to actually provide more polished, summarized summaries for residency applications. You can do personalized education. That's a buzzword. But personalized education involves assessment as well as learning. So teaching how people how to learn and utilizing, sort of how people learn to identify where the issues might be for particular individuals and actually even just for course content, right? So it's like an adaptability happening in within the context of learning. So for learning, for evaluating students and faculty, as well as for building clinical skills. So currently, we've all trained at some point with standardized patients, right? But you can actually have standardized patients in the AI setting, where students can ask questions of, sort of AI generated standardized patients, and have learning, sort of based on that. And if they make mistakes, that sort of those mistakes can be assessed through time. Many medical schools are beginning to use that sort of setting for persons. So those are some of the examples that actually promises in med ed, and certainly in the space that I exist, largely in med ed, which is the admission space. There's huge need for AI to help with decreasing admissions committee members' burden, for screening applications in or out for interviews, for actually identifying, what characteristics of applicants and students predict success in medical school ultimately. So there's huge opportunity, huge promise. But again, to actually do all of that in an effective manner, that I know AI is very fast and sometimes med ed can be very slow. That you really do have to have those, principles that I outlined earlier, in order to be able to have responsible use over time and to actually train the workforce to be adaptable, but as well be conscious of the downsides.
That's great. Dave, do you mind also talking a little bit about, so we've heard the medical education perspective. What about folks who've been in practice for 20, 30 years? How do we support and train them?
Oh, absolutely. So let's take a little journey back 20 years ago. So 2006, I'm a third year med student, Parkland Hospital in Dallas, and vivid memory, the attending doctor told me to do a literature search on pediatric kidney disease. And I did this report, and I'm reporting it, and he looks at me and he goes, obviously, your literature search is not equal to my literature search. And he was right. I was not good at going through PubMed and all these things, and it's a skill that you acquire over time. Now, when I have a medical student with me or a resident, they can use open evidence, and their literature search is equivalent to my literature search that it took me 20 years. Michelle said it beautifully that AI moves quickly. Sometimes education moves slowly. This is one area that we can move quickly. Our job is to enable the older doctors, the older clinicians, to use these skills as well. To how do we get AI embedded into your care? And that has to be done in ways that they're open to. We know that doctors don't read emails all the time. We know that they don't always want to watch YouTube videos. So we found that sandbox environments are typically the best way to teach the clinicians these skills.
I think, Dave, earlier you mentioned that it's really important, the question that is asked of AI, right? Because if you do testing, and all of us on the Zoom asks, sort of a question of AI related to a particular topic, we may get like completely different answers or incorrect answers. So actually, I think the education part of it and how to use AI and generating the right question to be able to actually get to that right answer is really important because patients' lives depend on it, right? Because if you put in, I was mentioning this yesterday, if you put in, somebody who comes up with tremulousness and a headache or, chest pain, and you just broadly put that in and it generates a differential for you of, endocrine condition, hypothyroidism or hyperthyroidism. That may not be the right thing because you didn't put in the right question. And so I think that's why it's really important for medical training to be able to, sort of cultivate individuals in the right way to be able to figure out, what to ask.
So I think what I'm hearing from you, Michelle, tell me if this is right, is that part of training is making sure you understand what's the important things to hone in on. Because if you don't know the important symptoms or the important backstory, if you don't have that background, you're never going to be able to use the AI tools in a way that actually augments your care positively as opposed to creating a bunch of noise or putting you in a different direction.
Yeah, certainly that's part of
Mhm.
it. Thanks.
Mm. Okay. I wonder if we can answer a couple of the questions in the QA. Asif, this one is for you. It's regarding AI bias. Given AI, this is from Fikru Bedada. Given AI is trained on existing data, which likely contains bias, what's the best way to minimize or avoid this kind of bias, or maybe evaluate and monitor for it?
Yeah, so we talked about or earlier about this concept of RLHF, which is reinforcement learning from human feedback. I think Michelle actually talked about creating benchmarks in these LLM models, making sure that as we are testing out these models that you actually have benchmarks and you make sure those benchmarks factor in the ethical and the biases. So this whole concept of looking at the LLM models and keeping the human in the loop, and human in the loop can mean many things to many different people. Part of keeping the human in the loop is training the models, rewarding helpful outputs, and penalizing harmful ones. And as we train these models, because the AI models um, they don't have the emotions and the data to support it, they're always going to give us as an answer. And we need to improve the alignment, safety, and the usability. And I think the critical tension, though, is who are those people reinforcing the learning from the human feedback? Because humans ourselves can have introduce our own biases. So you could, I mean, as simple as have more of a right-winged ideology or a left wing, and that can introduce bias. So I think part of the challenge of all of this is who is creating those benchmarks, who is creating who are the committees that are uh, making sure these biases don't exist, and are they introducing their own biases? So having enough of a group in that reinforcement learning from human feedback that is balanced. And I think that is a challenge with all the LLM models out there, which is who's actually looking at the models internally. And the transparency is always a concern of mine in these models. And the end consumer usually doesn't get insight of what those models are trained on or look like. So those are the sort of the things that keep me up at night as you started this whole conversation is, how do we call out the biases because they exist? And how do we keep the human in the loop to make sure that we reward the helpful outputs and mitigate the harmful ones?
Yeah.
Thank you.
Asif, I think those are fantastic. I'm sorry.
Please go ahead.
I think those are just such fantastic comments. I would be curious from this audience. A lot of what gets used in AI in the medical setting these days um, doesn't come from unstructured data, right? And it's really from the unstructured data that we have the richness of how, whether it's education or a patient might present, et cetera. So I'm just curious from this audience, sort of what do you think are the opportunities there are to actually better utilize unstructured data to help with sort of patient care and education.
Yeah, I think that's a perfect opportunity for me to jump into. That's a lot of what my lab has worked on at Brigham and Women's, and what my company now does at AI with Care. So I couldn't agree more. Structured data has a lot of problems, both overcalls, undercalls, sensitivity, specificity challenges. You see that in large data analytics and some of the papers that look at that type of analysis. I think there's so much nuance, and really the crux of the information comes from unstructured data, and that exists in clinician notes, that exists in the real findings of an echo report or a CAT scan or a pathology report. It really that's where the diamonds are, right? Like having that clinician interpretation and really synthesize understanding and assessment, right? That assessment and plan of what's really going on here and what do we need to do about that and what data are they using. And I think the advantages of one of the advantages of the electronic medical records is while it used to be that those things were completely distinct, right? That the structured data was in one section or tab way over here, and the note was way over here, and never the two shall meet. With the advent of a lot of these EHRs adopting incorporation of structured data elements into their notes, it really has become a bit of a one-stop shop. So, the labs auto-populate, the problem list auto-populates, the diagnoses auto-populate, the vital signs auto-populate. We're not in a world now where you have to go to 15 different data repositories that oftentimes live in different systems and are curated by different systems. You really have the source of truth. What the clinician is putting their finger down on is this is my judgment, this is my thought process, and this is what I want to do and why, based on the data here, where you really have a comprehensive set of data that you can make those types of recommendations and decisions on. So I really couldn't agree more that unstructured data is an incredibly rich source of important information, both for clinicians and for patients, to be able to really understand what's going on with their health and healthcare. I think that's important from education into research, which is a lot of where I spend my time and effort, also into clinical care and quality and safety. Getting into, I'll give my personal view, right? The revenue cycle management companies powered by AI have focused a lot on how do we, optimize more appropriate billing. I think, how could you do that better than by reading the clinician's notes, understanding what they're doing, why they're doing it, what they're focusing on, and what they're addressing for patients and how they're helping them to really actually be even more accurate and specific about the most appropriate way to compensate providers, teams, and incentivize patients to optimize their health. So I think that is an extremely rich source of data. I think it can and should be utilized much more. And I also think in terms of what we see oftentimes fail when companies, innovations, new technologies try to scale from one health system to another, this is actually a huge point of opportunity. Everybody has notes. It might be in a little bit of a different format. Their HPI might have a different structure. They might different sequence their social, medical, and family history. But in general, that template is largely there. And like any data model, it still operates on a garbage in, garbage out metric, right? So if the data exists, if there is information there that we can learn from and utilize to provide better care, to do better research, to educate better, it's, the large language models have really shown that they can surface that and make it more efficient and effective in the way that we can utilize and deliver it. However, that is necessary. It's not always sufficient, but it is necessary to have that level of detail exist so that the right user of that data is building that off of a high quality source. So I think I'm really excited to hear you say that. I couldn't agree more. It's a big part of what I do in my research and clinical life and what we're doing at AI with Care. And I'm very excited that that's something that really can help everything from the large health systems to the small health systems, from the students to the providers who have been in practice for decades. I really see that as a kind of a democratization force, because that crux of where we synthesize our thinking as clinicians and that clinical note really is so powerful.
Yeah.
And I just want to say with that I think the unstructured data comments are so powerful, and it's really driving a lot of innovation right now, across basic research tools that can be drawing from a patient's longitudinal record, the entirety of their longitudinal record, to allow physicians to better understand their patients. And Michelle, I saw you unmute. What would you like to add?
No, I was just going to say that, we're on an AHA webinar, and I think one of the benefits of an organization like the American Heart Association, as we think about just lots and lots of data, is the fact that, sort of AHA has access to data from thousands of hospitals in the country, and can act as, sort of a resource to have data across different populations, across different geographic locations, to be able to help inform guidelines, etc., and even to potentially perform clinical trials, within the AI-related clinical trials within medical data, pertaining to cardiovascular disease and stroke. And I think that that's very powerful. But the other side of that is the fact that a patient, is cardiovascular, it's neurological, it's renal, endocrine, etc. So it's always going to be really important for a powerful organization like AHA to have, these important partnerships that it has, because, medicine happens within an interdisciplinary lens, and AI has to happen within an interdisciplinary lens.
Michelle, that is so beautifully stated, and I think such a nice way to begin our wrap up of the session because we're getting close to the top of the hour. But the role of AHA with all of the data access that you mentioned, and one thing I wanted to bring up is that the AHA recently announced their AI validation lab, which is starting to address some of these questions that Dave brought up earlier for, the clinicians that can't do their own evaluations and validations of AI tools. How do you have and support a really trusted evaluation of tools that can then go on to empower folks in the community to use with confidence? And they're starting, AHA started with focusing on predictive traditional tools and rigorous evaluation of those given its resources. And I think it's this beautiful evolution of like what the professional society, what the AHA role is in supporting all clinicians. And I think it's just the beginning. So we're at 9:51 Pacific time. What I'd like to do is have everybody maybe provide any final thoughts, maybe one thing you hope the audience takes away from this webinar. And we'll start with Dave.
Great. So I specifically want to talk to anybody that's in rural America and is worried about this. You're not alone. I would say this isn't optional, but you have help. Lean on your partners, lean on your academic colleagues to help you with this, because this is how we're going to extend provider careers. This is how we're going to close access gaps. And this is how we're going to deliver better care without losing human connections. And that's really what's at the heart of medicine, is we're not trying to take anybody's jobs. We're just trying to make our patients' lives better.
Great. AJ.
Yeah, I'll say, just a note of optimism. I think the future's bright, right? Like these are still very early days in the implementation of healthcare AI. So, with our amazing partners and societies like the AHA, really excited to do this in a responsible, democratized and effective way that's really able to affect a lot of lives. And very interested in talking with anybody interested in research in this space, implementation in this space, kind of across the spectrum, and really excited to see this evolve. So thanks again for having me and for the opportunity.
Thank you, Michelle.
Yeah, I think that AI, despite some potential downsides, sort of has the major ability to be able to help support academic success and professional development, as well as ultimately patient care. And I think especially in the spaces AJ was talking about, in the research environment, it has the potential to promote rapid innovation. And the onus is then on us to ensure that that rapid innovation gets to all different types of people of all different walks of life.
Wonderful. And Asif.
The consumer adoption of LLMs has been unprecedented, especially with ChatGPT, over 100 million users faster than any technology platform out there. So patients come first. So we have to meet the patient upon their expectations. And that is called shared decision making and always keeping the patient at the center. We've talked about cardiology deserts here, about access. We've talked about making sure that it's equitable so that all people get access. We've talked today about really keeping the human in the loop, asking the right questions. And then I think lastly, making sure that the digital health literacy, both
No, I think we may have lost Asif, but I think he was doing such a beautiful job summarizing some of the themes from today.
Both
And
for the same page that we're transparent.
are you back?
Yeah, I'm here.
Oh, okay, wonderful. Sorry, we lost you just there for just a minute.
Yeah, I think the just to conclude for keeping the patient and as the center, just making sure again that we're giving access to that patient and making sure that when we make these decisions with the patient at the center, that we're equitable with them, that we're making sure that we're transparent, and that we're making sure that they're inclusive in the trials that we look at.
Perfect ending statement, keeping patients at the center of everything we do. And what I hope you took away from today is that, we don't have all of the answers, but we are continually iterating as the AHA, as health systems, as providers, some people as patients themselves on the best way to use AI to improve what has always mattered, which is patient health and our ability to deliver care to all. So thank you so much for everyone for joining us today. And with that, we will end our webinar.